Assalamu alaikum. Now I would like to discuss about an atypical topic: calcific uremic arteriolopathy. Calcimic uremic arteriolopathy or calciphylaxis. The pathophysiology is arteriolar and soft tissue calcification, local tissue ischemia, and necrosis. What are its risk factor? Risk factor is end-stage renal disease, hypercalcemia, hyperphosphatemia, hyperparathyroidism, oral anticoagulant like warfarin. What happens in here? In here, there is painful nodules and ulcer. There is soft tissue calcification on imaging. Diagnosis require skin biopsy where it shows arteriolar calcification or, or occlusion. Subintimal fibrosis. Management is analgesia and wound care, treatment of the risk factor, high phosphorus, high calcium, and optimization of dialysis. Vitamin K promotes synthesis of matrix protein that prevent vascular calcification and reduce the risk of calciphylaxis. Therefore, patients with vitamin K deficiency who are taking vitamin K inhibitor are at increased risk of calciphylaxis. So patients with vitamin K deficiency who are taking patients with vitamin K deficiency or a patient taking vitamin K inhibitor are increased risk of this calciphylaxis. And this calciphylaxis is the most common cause in areas of adiposity like trunk, thighs, and in contrast to atherosclerotic ischemia, usually presents with intact peripheral pulse. Lab studies can show high serum PTH and hyperphosphatemia, which is common in patients with ESRD due to reduced renal clearance of the phosphate. Although hypercalcemia, not hypocalcemia, is a major risk factor, normal serum calcium levels do not rule out the calciphylaxis because tissue calcium concentration may be much higher due to local inflammatory changes. Now let's look at some questions. Look here, look at the skin. Okay, this 67-year-old woman is evaluated for painful skin lesion that have evolved over past 1 to 2 weeks. She has long-standing ESRD due to diabetic nephropathy, for which she undergoes hemodialysis 3 times a week. There is BP is higher, 159/79, pulse 97, respiration 16, normal. Skin findings show this. Lab show elevated BUN, elevated creatinine, normal serum calcium. Look, there is normal serum calcium, elevated B1, elevated creatinine. Punch biopsy show calcification of the middle layer of the arterioles. Punch biopsy show calcification of the middle layer of the arterioles. Subintimal fibrosis and thrombotic occlusion. So subintimal fibrosis, middle layer of arterial calcification, thrombotic occlusion without vasculitis. Which of the following is most associated with increased risk of for this painful skin lesion? Looks like calciphylaxis and hyperphosphatemia. Calciphylaxis can cause hyperphosphatemia, hypercalcemia. Uh, okay, this patient has calciphylaxis, also known as calcific uremic arteriolopathy, which is characterized by systemic arteriolar calcification and soft tissue deposition with local ischemia and necrosis. It occurs most commonly in patients with ESRD, very high yield cause, who are on dialysis, who have had a kidney transplant or who have had a kidney transplant. Pathogenesis is multifactorial. Proposed mechanism include high calcium into phosphorus product with mineral deposition in vascular wall deficiencies, in inhibitors of the vascular calcification, phytoin A, and chronic inflammation. Calciphylaxis presents with painful subcutaneous plaques and nodules that can be violaceous or pruritic. The nodules can progress to ischemic or necrotic tissue, necrotic ulcer, become infected and can lead to sepsis, and mortality is high. Calciphylaxis is common in areas of the adiposity like trunk, like thigh, in contrast to atherosclerotic ischemia, usually with intact peripheral pulse. Labs can show high serum PTH, hyperphosphatemia, which is a common risk factor, and normal serum calcium level do not rule out the calciphylaxis because tissue calcium concentration may be much higher due to inflammatory changes. And those who have vitamin K deficiency and who are taking vitamin K inhibitor like warfarin is one of the risk factor of this calcific uremic arteriolopathy. Okay, look at this question. 50 years old man, hypertension, diabetes, okay, and stage renal disease. The patient is on hemodialysis for 3 years. He was admitted 3 months ago. Catheter-related infection, antibiotic, below-knee amputation 2 years ago. Non-healing or followed by non-healing foot ulcer. Physical examination show right carotid bruit. Over the next 5 years, the patient is at greatest risk of which of the following? A cardiovascular disease. Cardiovascular risk factor for ESRD patient. We know that cardiovascular risk factor for ESRD patient. So cardiovascular risk factor like coronary artery disease, stroke is the most common cause of death in end-stage renal. It's approximately 50% of the death even in younger patients. Traditional cardiovascular risk factor, hypertension, dyslipidemia, diabetes, left ventricular hypertrophy, sedentary lifestyle, advanced stage are highly prevalent in patients on dialysis. So that is all about calciphylaxis. Hope you enjoyed.